During Digital Health Festival 2025 in Melbourne, Australia, I was lucky enough to catch up with good friend of Talking HealthTech, Dr. James Somauroo, CEO of health tech agency Somex and host of the Healthtech Podcast. James and I hosted a live podcast recording up on the Oasis stage on day 2 of DHF, and we reflected on some of the key elements of James's keynote that he delivered on day 1 of the event, as well as the current trends and hottest topics that are shaping digital health today. We also opened up the mic to attendees live to ask their pressing questions, and we recorded the whole thing so we could bring you this episode of Talking HealthTech today. Since DHF was such a huge event, you'll notice there's a load of other episodes we recorded during the event on this feed, so make sure you subscribe to our weekly newsletter so you can be across everything that happened at the biggest health tech show in Australia this year. But right now, here's the session that James and I recorded live at Digital Health Festival 2025. Collaboration starts with a conversation, Team HealthTech. Let's make it happen. Welcome, everyone, to our session. I don't know what we call this, James. It's podcast meets podcast.
I know, yeah.
It's
who knows?
to the metaverse of podcasters. We'll do introductions in a second. So for those who aren't familiar with me, my name is Peter Birch. I'm the host of Talking HealthTech. It's a podcast and membership community about technology and healthcare. Actually, if we go to the next slide too, we've got something for those unfamiliar with how podcasting works. I had to explain to someone yesterday how a podcast works, but that's healthcare for you. But then there's also people who do binge the content across all the different platforms. From a Talking HealthTech side, we've got content up on YouTube, also Apple Podcasts, Spotify. We're recording a lot of content over at our booth as well. James, did you want to tell people about your world?
Sure. So my name's James. I am an anaesthetics and intensive care doctor by background. I practiced clinically for 5 years. I've done lots of different things in leadership, policy, innovation in the NHS and wider commercial health sector. So I've run a couple of accelerators. But the other side of my life has always been media. So I write for Forbes on health tech as a contributor. I host the Healthtech Podcast. I've got a news brand called Healthtech Pigeon. That's a newsletter and a panel show podcast that we do every week, wrapping up the news in health tech. But the main show for me is that I am co-founder CEO of Somex, and Somex is a communications and creative agency for health tech, biotech and pharma companies. So over in the UK and increasingly in other countries. I bored you enough, Pete.
No, yeah. Go on.
I'm off.
Yeah.
So we do all comms and creative stuff.
Before, it's all right.
Yeah, exactly. Anything under the marketing umbrella we do for health tech, biotech and pharma companies. And increasingly looking at a few other countries as well. So hence I'm over here in Australia having a look at how we might land over here.
Man, I got in touch with you when I was looking at starting Talking HealthTech back in 2018, and I'm sure you were up to a single-digit number of episodes, because I was looking for a podcast about
0 listeners, but 10
episodes. And so we've been in touch ever since. We've done a few virtual episodes together, which have been fun. So it's great and we've caught up last year in Europe, so it's great to be here today. We thought it'd be a good opportunity to be able to do a live podcast episode here, and whether it goes out on the Talking HealthTech podcast or the Healthtech podcast. Notice that the T in Healthtech on my side is a capital T, but the T on it, we haven't decided whether that's correct or not. That's one thing James and I haven't. Although you did squish health and tech together at some point.
Yeah, it started as the Health-Tech podcast when health tech wasn't even a word.
Yeah.
And I say this to people a lot because when I first got into health tech, when I was, still a doctor, I was looking at startups doing stuff. It was basically called health IT.
Yes.
And there was no health tech at all. And then because of like the startup Silicon Valley stuff, there was clean tech and green tech and fintech and these tech, that tech, and then eventually sort of health tech started to come about. But for SEO purposes, literally just had the dash in there. So I captured health and I captured tech just to try and get anyone to care about what health tech actually was. So,
but we got there. It's good. It's good. So do check out either platform. There's links for that you can do that, because you'll catch this episode we're recording now on one of those at some point in the coming weeks. What I did want to do is open up to Q&A, because we could ramble about anything in this particular episode, but we want to take feedback from you. To make the Slido work, I believe it just magically works like this. and by doing it like that, perhaps the technician at the back there can assist with the Slido, but if not, it sounds like he's got a text message to send. It's okay. But we had a backup plan for in the event that the Slido didn't work. So there may just spin up as we go. If it does, would love your feedback and questions as we start the conversation. But, mate, you did a plenary on a very much bigger stage than this only yesterday here at Digital Health Festival. What were you talking about?
So my talk yesterday has basically been the culmination of a year's worth of conversations that I've been having on the Healthtech podcast, because I talk to a lot of entrepreneurs. I'm on episode 400 and something. I think 400 even comes out next week. But I've been talking to a lot of people about, obviously, AI. AI has been a huge deal. It's everywhere in health tech right now. It's everywhere in healthcare right now. But because AI can go everywhere, that doesn't necessarily mean it should. And that's what my talk was about. What's the vision of healthcare that we're actually deploying AI into? Because AI can literally redesign everything. We could do away with hospitals. We could do away with so much of healthcare. We could completely, you wouldn't need consultations. You could, collect all your biomarkers from everything at home and it could just happen. And there's so much that we could design healthcare into. And at the moment, we're sort of in that faster horses with AI. We're trying to just put AI, making everything slightly better, slightly quicker, everything that we're doing now. But my quest has been, what's the vision that we're actually developing AI into, and what should that actually be? And I guess where that starts and ends for me is, what can AI not do? So in a world where AI does everything, robots do surgery, you never see a human in your entire healthcare journey, then you have to ask yourself, where should the human be? What can AI therefore not do? And that took me to empathy. And to cut a very long story short, there's 3 types of empathy: cognitive, emotional, motivational. AI is incredibly good. It's actually better than humans at cognitive empathy, which is understanding what you're going through and reflecting it back. So if you say into ChatGPT, oh, I've got a headache, ChatGPT is amazing at saying, oh, that sucks for you. I bet that's terrible. I bet it's really hard to concentrate. Do you want me to do this for you? Do you want me to do that? It's very good at that. But because it doesn't feel anything, because it doesn't actually have an impulse to help you, it lacks emotional and motivational empathy, so it always feels empty. So my talk was all about that. Where, therefore, do we put the human? Because actually, if AI is very good at cognitive empathy, there are plenty of places where that's enough. But you certainly don't want AI giving you a cancer diagnosis. You actually want a human to put a hand on you and an arm around you in that scenario. So as humans, just because we can, should we? There was a great study done by Dartmouth University out in the US, came out last month. They did a randomized controlled trial on a large language model that they had trained called Therabot. And they deployed Therabot in a research setting, so they got ethics approval for this. They had 210 people with major depressive symptoms, anxiety, and high risk for eating disorders. And they deployed a large language model chatbot to treat them, first line. So we live in a world where that is happening, where we have declared that that is okay. We've said that if you're a human and you're suffering, we're allowing an AI to see you first. That is the world that we live in. So in a lot of ways, the horse has bolted, but my conclusion of the talk was that, should we not put a framework around what we actually want here from healthcare and health tech, just because we can? Should we? Therabot, by the way, worked. 51% reduction in symptoms, which again is good and bad. It's good that it worked. It's bad that now, okay, that might be a new baseline. Is that the world that you want to live in, where you see a chatbot first?
Yeah, and then all the other questions around baseline of we expect a certain amount of accuracy and capability of a human versus what we'd expect at a very high level on a machine side.
Very true.
What I'm thinking, we'll continue this conversation in a second, but rather, because the Slido looks like it's malfunctioning, we'll go to old school fashion of passing a mic around, because I want to make it an interactive session. So we'll have microphones ready for walking around, perhaps, if anyone has questions and things they wanted to speak about and comment on as we continue to banter in this live podcast episode recorded at Digital Health Festival 2025.
Back to what you were talking about before in terms of the artificial intelligence and, just because we can doesn't mean we should. I don't know, I still very much wear my two hats of healthcare, wear figurative hats of, talk about innovative opportunities in healthcare where, all of these things, the large language models can be applied and the efficiencies that potentially may happen. And then I literally go into my GP clinic or my dentist surgery and still getting handwritten notes and things. It feels like that chasm is really far, but I guess there are pockets of these things actually happening too. So I wonder, I actually raised this at the New Zealand Trade and Enterprise dinner 2 nights ago as kind of a thing as well. I remember back when I was much younger, it reminded me because my son Lincoln is wandering around somewhere. By the way, if you see someone who's kind of looks like me but is up to about this height, it's my son. It's not me through the dryer, but he's probably at the pinball or the skeet thing. So go have a chat with him. But it reminded me, probably I was only a few years older than him, my family business prior to all of this that I was brought up in, my granddad ran a photography business. And, it was at in the late 1990s or early 2000s, it kind of got to the stage where I was getting really involved in the business. And by then it was, dark rooms and windy film and the 36, shots on a camera. And around that time, digital photography was kind of emerging. It was around and it was possible. But, given that in the family photography business, you weren't it would be irresponsible of you to take out a digital camera to go and take wedding photos or to take a debutante ball or something because the quality wasn't there, the reliability, batteries were shot, all those reasons. It was much more reliable and safer to use your analog camera. But then you had to switch out the film and all the things that you do with the old thing. And it took like 3 weeks to see it afterwards. Whereas now, if you went out today at a wedding at a wedding to take photos and you did it with an old school camera, sure, there's a lot of artsy elements to it, and I've got nothing against the old school style, and people still use windy film, but it would be irresponsible if that was your core kind of thing to use, the old way. So my granddad at the time, when I was he was like, oh, hey, come into the business and do all this. I'm like, hey, so have you seen this digital photography stuff? Like, should we be keeping an eye on it? And his take was, oh, look, that's a toy, that's something to play with. Look, we've got, jobs to do right now. And long story short, he kind of wound down the business because he didn't back the horse of digital because it was a passing fad. I hear a lot of hospital CIOs, CTOs and clinic owners and things saying, look, all of this sounds cool on the artificial intelligence side, but I mean, my patients I see on a day-to-day, the reality is it's just not a priority, and some people still don't want to give me their phone number because they're concerned about what might happen. How big is the chasm do you find elsewhere around the world of what the reality is of healthcare versus all these cool things we talk about on stages?
It's there, but in the UK, I would say we're making a lot of headway very quickly. I think, like that Dartmouth study that I mentioned, academically, this stuff is getting noticed of, oh, hold on a minute, it works. I don't think with something as powerful as that you can go from a model in mental health provision of an entire service and going, oh, we need 40, 50 humans delivering this and they're at full capacity. So now all of a sudden I can deploy a chatbot and knock out 51% of the people that are going to get treated by it. It's impossible to ignore. In the UK as well, we have a company called Accurix that delivers communication software and ability to primary care. It's in 98% of GP practices. They just partnered with an AI scribe and just deployed an AI scribe to 98% of GP practices in the UK. And Heidi have come out last week saying, like, oh, we'll give it to GP practices for free for 6 months now. And so, it only takes one action, and all of a sudden, people are asking for forgiveness, not permission. And it's like, hold on a minute, this is a real thing. And I think that's the thing is, like, when you look at AI and you look at the ability for it across multiple domains, we're moving from a place, I think, of, oh, I don't understand it, I'm going to veto it, to, hold on a minute, it can be so effective, I might not know how it works, but actually let's deploy it and then mitigate. So it's not vetoing anymore, it's let's deploy it and then mitigate. That seems to be a change, it seems to be a feeling, because I had the CEO of a notified body on my podcast, and a notified body is an organisation that regulates medical devices and says, "Oh, a medical device is now CE marked in the UK, which means you can sell it." And I asked him, "Are large language models going to get regulated anytime soon?" And he said, "Yes, 100%. I am 100% confident that large language models will get regulated." And I said, "Really?" Because you hear all this stuff about black box and lack of determinism. So if you ask it the same thing 3 times, it gives you 3 different answers. And he said, "Well, first of all, the black box isn't an issue. Loads of black box stuff gets regulated all the time, so not bothered about that whatsoever. The determinism, we're moving to a place of mitigation, not veto. So can we mitigate against the deterministic or the lack of determinism rather than anything else?" So that it feels like we're in the story we're going to tell later about This was the moment. I genuinely do feel that we will talk about a world pre and post AI, and that we're in the transition right now. Literally that news about, Accurix and Heidi and Tandem last week, like now you've got an AI scribe across primary care. Like all these things are literally happening. Skin Analytics in the UK, a company that, you take an image of a skin lesion, it diagnoses with AI software. I can say that word now because they got class 3 medical device certification for that. I commented on their post, "This is health tech history being made." This literally is the moment where these things are now changing. So there is an AI software out there that will diagnose, and I can say that, it will diagnose a melanoma to over 99% accuracy. I believe it's 99, it's definitely in the 90s, with appropriate safeguards, appropriate escalations to humans if necessary. That is being deployed. That is a new dermatology service in the UK. Nice. The National Institute for Clinical Excellence in the UK that says what we should be doing with this stuff has said that it should be first line. That happened last week.
So this is the time.
We're in it. We're in the story. We're in it later. I'll tell you.
Well, if you want to contribute to that story and contribute to this conversation, do raise your hand if you've got questions or comments, and we'll pass the mic around. We're going to go the old school microphone. Thank you for that. I see a question over here and a question here. That'll probably... Oh, and a question here too. Sorry about that. I think you got pipped at the post.
Hi. I'm new to both of your podcasts, so I'll definitely be having a check of that afterwards. Awesome. So that's great. I know there's lots of stuff here at the moment about looking into AI to ease doctor burden, to get, clean communication at the front end. Do you guys in your podcast, or will you be touching on AI use post-patient discharge with health data, looking at health information managers, clinical coding, all those works? Because it seems to me, I'm in that field, that there's lots of advancements up the front with actual clinical care to help streamline that. But then once it's discharged, or the post-data stuff that we actually use to help allocate funding, that AI model has sort of been left by the wayside. I think it's appropriate to have clinical care up front to get that sort of streamline in the communication as best as paramount. But do either of you guys touch on in a patient journey, like after discharge?
I know great question. It brings me to a recent episode we did, which doesn't speak directly to your question, just the challenge of even getting to that point in the first place here in Australia, particularly in private hospitals, where firstly the shortage of clinical coders that we have generally, and we don't even have EMRs in most of our private hospitals anyway. Most private hospitals in Australia still don't have an EMR. We've got some work to do here. But the public hospitals, you're right, in terms of the hype and excitement and interest around the particularly the AI scribe space right now is getting a lot of attention. So I think that's sucking a lot of growth for the right reasons too, where we're feeling the most amount of pain. I can't think of particular examples, and I definitely will straight after this conversation too. But it's more around there's so much. This is where this conversation continually goes. Well, it sounds like something we should be doing, and we can. And I know there are plenty of examples of that out in the space too. A lot of the conversations we've had on the pod recently around the challenges even to get to that point. And so that's why a lot in Australia we talk about, the great work that's happening with Sparked and the fire standards and the interoperability, just to be able to. I feel like a lot in Australia we're spending a lot of our time helping us get to this point to where we can even just walk, let alone run. But there's probably good examples of it out there, but we're still probably burdened by the whole garbage in, garbage out type mentality as well. I don't know if there's anything happening on the UK side.
I'd love to talk about it. I haven't. Especially the clinical coding side, it's less of a thing, I guess, in the UK, and definitely on my podcast. But I talk to entrepreneurs, leaders, everyone across health tech, whether they're early stage, late stage. So yeah, happy to talk about it.
Who else? Let's keep the conversation going. Let's keep them snap. Oh, cool. Let's run this way. I saw that one came up first, so we'll go there. Yeah.
Thanks. I actually attended your session yesterday, and one of the things that you put up on a slide was the framework that you suggested for where AI versus human empathy comes in. And I remember up in the top right-hand corner, you had human empathy. So my question is, with that, you didn't actually go into any specifics of who and how would we make the decisions on how much empathy is required. How do we measure that, and in different clinical settings as well, like human empathy in a paediatric ICU situation versus maybe in a general med. So what is the conversation around those decisions about how much and who decides on the human empathy factor?
Excellent question. My personal opinion, well, let me explain for everyone that hasn't seen that slide. So I put up a 2x2 of where I think AI should be deployed. My whole thing about my talk, by the way, was that the one question that I think we should ask of AI, or certainly one of the questions we're not particularly asking, is does it communicate, yes or no? And if an AI communicates with people or patients, because there's plenty of AI that doesn't, but if an AI communicates with people or patients, we should be asking ourselves, what is the clinical risk of this situation? And high clinical risk would require humans in the loop, or human empathy, or humans to be having discussion. And then a low clinical risk, we could perhaps have a framework where we start deploying AI. So that's the context there. And the reason for that is that the horse has bolted. We're deploying AI everywhere, the Dartmouth study, et cetera, et cetera. We're deploying AI into mental health. We're deploying AI into all these places where it communicates completely all over the place right now, and we're letting that happen. So what I'm talking about is potentially having a corner of this where we say, we are ring fencing this for humans to talk to each other. And so things like, I said yesterday, things like delivering a cancer diagnosis. You don't ever really instinctively want to see a world where you're delivering a cancer diagnosis with an AI. That doesn't feel right. So in answer to your question, the real answer is that I don't know yet. I don't know how we make that decision. But I suspect that if we had a sensible discussion as a community, as a particular organization, that you could find a way of deploying some sort of framework that allowed every clinical situation to be scored, to be put into, as I say, a framework that we could say, well, clearly above here it's human empathy, but that would allow then the safe deployment of AI in other places. Because part of my argument was that we could say, okay, every communication should be human. We're going to aim for that. We're going to put AI absolutely everywhere except communicating with people or patients. I actually held that view for quite a while. I said that it was unethical to actually do that in a world where we didn't have to. So I said we should do that. But the pushback, and actually the reason I changed my position on that, is because in a world where, let's say I used an app called Woebot, where I had no past medical history of mental health conditions, I was not particularly symptomatic of anything, I had no red flags, but I wanted to prop up my mental fitness. Using Woebot, which was just a CBT app that I knew was AI, was enough, and that was enough for me. Now, in that framework previously of you reserve humans for communication, I'd be on a waiting list, I'd be waiting for that therapy. That's not particularly sustainable when it can be deployed by an app that does cognitive empathy. So what I'm saying is that by reserving a certain level of human empathy at the very top end, we can actually deploy AI to be communicative in the places that it's safe, effective, and that makes healthcare more sustainable. That genuinely solves a huge problem and allows us to deploy humans in lots of other places. So that was my argument. In terms of how we decide that, I think there's a lot of common sense involved. Again, common sense has got a standard distribution of how that's distributed amongst population, so you're always going to get some outliers. But I don't know, and I think that's the conversation that I want to start. That's the thing that I want to see happen. But yeah, I think it's a great question.
Hey, look, we've got a minute left, so we could speed run an answer to it. We're pretty good at sticking to time because this thing blows up at 0 seconds because it's counting down from 53. So let's be quick and we can do a speed run answer.
Do you think, so there's a lot of discussion around AI, do you think that's going to increase the digital divide out in particularly primary care? Because the barriers are cost, accessibility, those types of things, along with risk. So do you think it's going to increase that digital divide?
Yes, I do. I think it's a big risk we need to watch out for because I see a world where, in what I just talked about, I see a world where humans, very expensive, AI, very cheap, Dartmouth study, etc. These people get a load of AIs just doing mental health support. These people get a lovely human reserve for them because they can pay for it. I think that's a massive, massive risk that we need to mitigate for.
My thoughts align with that, and there's a whole other global developing nations answer that would be really fascinating to dive into, but we're going to run out of time here because we're going to respect all the speakers that will be coming here on stage. I'm on other stages as well. I'm going to call this session the Healthtech Bromance session. We might run with that title for the episode when it's released, so do check out the Healthtech Podcast with Dr. James Somauroo and Talking HealthTech with me. Thanks so much.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.